Good evening, everyone. My name is Simran Chaudhary, and on behalf of Voice of Healthcare, I warmly welcome you all to a nationwide virtual initiative, National Prostate Cancer Forum Navigating Innovation and Treatment Frontiers, organized by Voice of Healthcare and supported by Bharat Serum and Vaccines. This forum aims to bridge knowledge gaps among clinicians by addressing challenges in the fast evolving prostate cancer treatment landscape with a focus on India's unique healthcare context. We will explore cutting edge innovations, foster interdisciplinary collaboration, and enhance clinicians' ability to integrate advanced therapies, diagnostics, and personalized approach into their practice. So, without any delay, I'm delighted to introduce our esteemed panelist for today's discussion. Dr. Kishore T.A., Senior Consultant, Uro-Oncology and Transplant Surgery at Aster Medicity, Kochi. Dr. Rajesh Patirar, Senior Consultant, Medical Oncology at Chitturam Hospital, Indore. Dr. Vineet Talwar, Director, Medical Oncology, Rajiv Gandhi Cancer Institute and Research Center, Delhi. Dr. Krishna Prasad, Chief Medical Oncologist, Mangalore Institute of Oncology, Karnataka. Dr. Shyam Aggarwal, Chairperson, Department of Medical Oncology at Sir Ganga Hospital, Delhi. Dr. Ravi Kumar Vategaonkar, Medical Oncologist, Aditya Birla Memorial Hospital, Pune. Dr. Ankit Patel, Consultant Oncologist and Hematologist at Surat Oncology Center. Dr. Bharat Bhosale, Medical Oncologist, Aditya Birla Memorial Hospital, Pune. Welcome all the panelists to our panel discussion. Now, I have the pleasure of welcoming Mr. Rajiv Arora, President and Cluster Head, Critical Care, Oncohematology and Emergency Medicine at Bharat Serums and Vaccines Limited. So, I would like to request to share your opening remarks.
Thank you, Simran. I think you said it all. For me, it's one of the very nostalgic moment having such an eminent faculty pan India, on the forum of VOH, and we shall be addressing the emerging landscape for CA prostate. And I think what on the occasion of World Cancer Day, what Bharat Serum and Vaccine, which is a part of mankind now, mankind pharma, a bit that we could do as a commitment of our, presence in oncology, it to have such a strong galaxy of speakers at one forum, with whom I have traversed my last almost 3 decades of journey. So I think a deep gratitude to each one of the faculty present here, most of them whom I know personally, and I think with this I would hand over to the moderator, and without saying further, because what the audience need is to hear these speakers more than my saying any few words. So thank you each and everybody, and then it's a very warm gratitude from on behalf of my and my BSVT here. Thank you.
Thank you so much, Mr. Arora, for your opening remarks. Now, I would like to invite Dr. Bharat Bhosale, who will be leading the discussion today. Over to you, sir.
Thank you. So one correction, I'm from Mumbai, Bombay Hospital, not from Pune, and Dr. Ravi Vatekar is from Pune. He is a leading medical oncologist from Pune. So I'm very happy that among the panelists, we have 2 sessions, and Dr. Vineet Talwar is the director, and he has been mentoring all of us, most of these panelists, and the another panelist will join in the second segment, and we have been looking at them and learning so many things. Sir has vast experience, so he probably has seen the time when the treatment has started, no, in niche, and now we have so many agents. So, sir, we would like to know, learn again. Every time we try to know, learn many things from you about, and especially you are the. He is again has his expertise in urological, including prostate cancers. But as I know, see, we have a urologist, the surgeons, where the solid tumor, generally solid tumor patients, know they go to the surgeons first, and in prostate cancer, the urologist is the key point, center point for the diagnostic screening. So coming quickly to Dr. Kishore, now 4th was the World Cancer Day, and the theme was theme is for united in a unique way. Every patient is different and need a precise treatment, but for the treatment we all have to advise, we all are here. We have multidisciplinary teams looking after all these patients, and we actually have been seeing how the outcome has improved. But when we talk about a lot of screening, and prostate cancer has been in the list in the Western countries for screening, I would like to ask you how challenging to utilize the screening methodologies, and do you see any change in the way screening has happened? Because I see many laboratories are promoting the ctDNA based markers, but in my knowledge, it is the digital rectal examination and PSA is the only thing, because nothing can replace a good clinical examination. Yes, PSA is there as a biomarker, but in prostate, no, you are aware that many conditions which you treat is a prostatitis, and that also causes some increase in the PSA. And increase in PSA, patient comes to you, they are in stress. So how do you address? You can elaborate in detail.
Yeah. So thank you, everyone. I'm an outlier today, it seems. I'm a only sole surgeon here. So, as you said, no, most of the people they reach out to surgeons first, and then eventually they go to the medical oncologist. So, the onus is on us to have a proper treatment. So, especially in my part of world, we are still in a PSA era because PSA is done quite cheap for 300 rupees, 500 rupees in each and every lab. And people are, most of them are aware, especially the middle and upper economic strata, they're aware of the PSA and they do. And most often it is picked up in this routine checkups, no, the master health checkups or whole body checkups, they do that. And I mean, to most of their surprise, we don't get any symptoms generally, as you know. Until the prostate cancer is advanced or metastatic, you don't get any symptoms. So they might be coming for a BPH treatment, and eventually we might be finding out a prostate cancer. So these are the scenarios that people usually come to us, either BPH symptoms or elevated PSA in a routine health checkup. So again, one conundrum that we have in India is that we have overlap with prostatitis. So the prostatitis also mimic malignancy in terms that the PSA might be high even in patients with chronic prostatitis. So if you say like a PSA of 6, you're going to go for biopsy in 100% United States with absolute certainty. On the other hand, we are a little bit reluctant to do biopsies initially unless you have a solid clinico-pathological or clinical or MRI related findings. Otherwise, we are a little bit reluctant. So we give a course of antibiotics, see that PSA is coming down, and then only we go for the biopsies. So we are not as enthusiastic as our Western counterparts, but still we do get a large number of prostate cases, and I feel it's ever increasing. Does
Yeah,
that
very
answer
important.
your question? Yeah.
So yes, very importantly, you mentioned that we are seeing large number of prostate cancer cases, after doing these biopsies. But there are two spectrums where you have a very low grade or slowly growing tumors, which we are picking up early stages. Yes, we do want to pick up those cases and treat them. And the other other side, you are aggressive, the biology might be different. So always there is a chance of picking up and passing on the survival advantage to the patient. But at the same time, we have to be careful by the lead bias, because the latest data which comes from the USA, they are seeing that mortality is going down, but the incidence is increasing. So is it because of picking up more cases which we did not know, we never used to pick up that something? But yes, as you mentioned, in India, the geriatric population is increasing, the average lifespan is increasing, and prostate cancer being the disease of old age, this is going to be challenge, and it significantly adds some mortality. The important challenge is to treat or not treat. Sometimes pick up them in early stages. You have group 1 PSA is low, and patients average survival probability in the next 5 years is also important. So coming to Vineet sir, to addressing this, picking up the cases in early stages and to treat or not to treat, because these are elderly patients. In the last 2 decades, we have seen a lot of molecular markers coming up. After oncotype DX we use for breast, they have tried something in prostate. There are other markers. Since almost 10-15 years, we have been hearing about these microRNA based markers like prolaris and other things. But I really don't see them in practice. We still use PSA and clinical tumor size, the Gleason scores. What is your take on that?
No, I think, Dr. Bharat, you're absolutely right. Uh, when we talk of markers, we have to see the clinical connotations with them, where we can use them specifically. So, as all of us know, prostate cancer, the ones which we treat as medical oncologists, is predominantly in the metastatic arena. And if you think about localized prostate cancer, then probably the surgical and radiotherapy, they are more in vogue. So in metastatic prostate cancer, we divide into three parts. One is a hormone sensitive prostate cancer, and there is a new entity like M0 castrate resistant prostate cancer, where it is non-metastatic. And then thirdly, we have the CRPC, that is the castrate resistant prostate cancer. So clinically speaking, if we talk of markers, predominantly they are in the CRPC, that is the castrate resistant prostate cancer arena. And there we have seen initially there was a marker like ARV7, which could distinguish between whether we have to give uh, drugs like abiraterone or enzalutamide, because if that is mutant, then probably these drugs won't work. We have to go to other drugs which are there. Then came the BRCA1 and 2 and ATM. There was a trial known as the Profound trial, which found conclusively that these three genes, if they are there, then you can target them with certain drugs which are known as the PARP inhibitors. And then after that, there was a registration trial in which uh, there was an entity which is known as microsatellite instability. And it was found that whenever you have this microsatellite instability, irrespective of the organ of origin, or you can say agnostic. Agnostic means I don't know. If you have MSI high, that is microsatellite instability high, then probably you can target it with the immunotherapy drugs. And apart from this, there is another downstream signaling pathway, which is PTEN. If you have a PTEN loss, then probably that you can target with the newer drugs like capivasertib. And these key biomarkers are there, which are helping us in defining and in sifting out the cases which could benefit more, apart from the conventional anti-deprivation therapy or anti-androgen therapy drugs, that is the ARPIs. A word about nuclear medicine, which we call as theranostics. So there, as a routine, we are using the prostate-specific membrane antigen, that is PSMA PET scans, for diagnosing the disease. So if you have the sites which are avid for the PSMA, then probably with the radiopharmaceuticals like lutetium and actinium, you can target them and get the desired benefit. So all these drugs, they started, as third line, fourth line, when it was the castrate-resistant prostate cancer. And now slowly they are creeping up. And from the CRPC, some drugs like PARP inhibitors, they are going into the hormone-sensitive prostate cancer arena. So I think in times to come, they will crawl up and they'll go into the other non-metastatic indications and there are a lot of trials which are going to give us the answer regarding that. So as of now, we have these 3 or 4 biomarkers which we can use to the fullest. If you have any one of these onco drivers, probably you can get the desired effect.
Yeah, absolutely. Thank you, sir, for taking us across the management of metastatic castrate sensitive as well as prostate resistant. So there was a era when hardly no chemotherapy was a part of treatments, only androgen deprivation, and there were some estrogenic agents. And the landscape of metastatic prostate cancer has evolved so much. Coming back to Dr. Kishore, in the surgical part, when we pick up these cases in early, no screening is going on. As you mentioned, people come with high PSA, and you do biopsies. How do you know these early stages of prostate cancer before going into metastatic stages? How do you approach it? And then I would like to specifically ask you about oligometastatic. Do you think these cases also, if responds well for surgery, because now chemotherapy, targeted therapy, genomics, precision medicine has taken a front stage. Do you utilize in the upfront cases in early stages? Because radiation is also coming up in the early stages as an alternative to the surgery, and robotic surgery has evolved in various cancers. But specifically, I would like to comment here. Prostate is one disease where I feel personally the robotic surgery has a bigger role because you have limited access in open surgery or laparoscopic surgery. That is what, as a physician, my knowledge is. You can educate all of us about robotic surgery and know how do you risk stratify your patients for surgery prostate.
Yeah, so as you said, no, we also get two spectrum of patients. One is like very early case, say Gleason 7, PSA 6, 1 or 2 course positive. On the other hand, we do get like Gleason 9s, multiple course positive, very high PSA like that. So as far as surgical part is concerned, the outcome is best for the early prostate cancer because the surgery is very aggressive.
I think we lost him. Yeah. Meanwhile, Ravi.
Yes, sir.
Yeah. So till the time the surgeon is back, we are talking about early stages of prostate cancers. And nowadays, every patient is well aware about PET scan. We have audience, patients as well as the caregivers, as the general physicians as well. So a lot of people are talking about the PSMA therapies, as sir has mentioned, lutetium and other kind of therapeutics. And then we call about the role of PSMA PET CTs.
Right.
So can you just briefly tell us a PSMA PET as a part of early
Okay.
staging
Management
as well
of-
as
Yes.
deciding
So-
about the therapy, PSMA therapy?
So in other solid tumors we use PET CT, but in prostate cancer we generally use PSMA PET CT because PSMA PET CT is better than normal FDG PET CT in prostate cancer. Why this is better? I will tell you. PSMA PET scan is basically used in diagnosis of early prostate cancer as well as advanced prostate cancer. Uh, when compared to other modalities like FDG PET CT, bone scan, then CT scan, MRI, ultrasound, it can pick up prostate cancer very early at low PSA level. So it has got high sensitivity as well as high specificity because PSMA is prostatic membrane antigen which is expressed exclusively on prostate cancer cells. So when we see PSMA avidity on scan, it indicates okay, it is probably prostate cancer. It is highly specific as well as highly sensitive as compared to FDG PET CT. So basically, with the help of PSMA PET scan, we can have higher sensitivity in diagnosis local disease as well as metastatic disease. When relapse, it can pick up relapses at low PSA level. So early diagnosis of relapse, it has got better staging because at low PSA level also we can see metastatic disease which has missed on other scans like CT scan or FDG PET CT scan. Okay. So another thing is there is new therapy which already discussed by Dr. Vineet sir, Lucium PSMA therapy. So when prostate cancer is PSMA avid, then this therapy we can try. So it is used for targeting purpose. So whether patient will get benefit from PSMA therapy or not. Another advantage of PSMA PET CT is to stratify disease, whether it is indolent disease versus aggressive disease, because PSMA avid disease generally they are aggressive disease. So initially PSMA disease they are aggressive, but with the help of newer therapies like Lucian PSMA therapy, it has got newer life, and they become more sensitive to treatment, and it has better survival as compared to PSA negative scan, which are have other mutations also, and some PSMA negative they transfer into neuroendocrine tumor, which has very aggressive cause. So PSMA PET scan is useful for stratification of prostate cancer also. These are some uses of PSMA PET scan in redefining prostatic cancer management.
Thank you, Dr. Ravi. Coming back to Vineet sir, so now he has mentioned about PSMA using for early stages as well, helping to staging, and later on using the PSMA therapy. Our surgeon friend still has not joined us. So FDG PET and PSMA PET. No, we have chemotherapy, we have anti-androgen therapy, and now, as you mentioned, there is lutetium therapy and other therapies where we can target these. So, sir, for our audiences, because people are aware about FDG PET, and now we have PSMA PET. So, do you use both or one when you come to know? Because, as you mentioned, these treatments from third or fourth line that they are coming in now in the upfront. Even lutetium is coming up front. And then I'll come to know you about specifically for immunotherapy. So you can talk about FDG and PSMA for deciding for these therapies.
Yeah, I'll take on from where Dr. Ravi stopped. Whenever you do a PSMA PET scan, you find the lesions on the PSMA PET and you see the avidity. So when you see the avidity, you find that they are highly avid, then probably, you can get away with the PSMA PET scan only. But sometimes when you have treated the patients, or sometimes there is a de-differentiation of the tumor, that means it becomes a high-grade neuroendocrine or a small cell variety. Then what happens is the avidity of the PSMA PET, it decreases in certain areas which are ascribing to the high-grade NEC, that is the neuroendocrine cancer. So in those situations, when you find that on the scan, the tumor load is too extensive, and you find that the PSA levels are not corresponding. For instance, you have extensive skeletal mets and you have lymph node mets and visceral mets, and PSA is just about, say, 40 or 60. And then you find that there are certain areas which are not avid with the PSMA PET. In these conditions, I think it is prudent to do a dual PET. By dual PET, I mean one is PSMA PET and the other is the FDG PET. And sometimes you find that when you do the FDG PET, those areas which are not avid, they suddenly become avid with the FDG PET. So then, why is it beneficial? It is beneficial, one, as to why the PSA is not rising and the volume of disease is so high. So what we do is we try to target those areas which are PSMA non-avid and which are FDG avid, and we do the biopsy specifically from those areas. So by doing that, we can, get the answer whether it is transformation into the high-grade neuroendocrine carcinoma, that is a small cell variety, or not. And the reason, of course, is very clear, because on one side you are talking of just hormonal therapy, or uh, you talk of hormonal therapy plus some chemotherapeutic drugs, whereas once it becomes a small cell variety, it is chemotherapy all the way. Secondly, as far as the prognostication is concerned, if you have CA prostate, the conventional one, which is adeno-CA, there the prognosis is much better as compared to a neuroendocrine, that is small cell variety. So variety of things become clear once when you do a dual PET in these scenarios. So I think wherever you see that the avidity of the PSMA PET is not conformant and the PSA levels per se are low with a high volume disease, these are the areas. Or, if you find that the patient has started deteriorating very quickly, and the performance status, which is there about, say, a couple of weeks back, it has gone down a lot. So these all are the pointers, where you should do a dual PET and confirm and then proceed.
So thank you, sir. Thank you very much. So for the audience, it is important to know there are different types of PET scan. They are utilized not only for just staging, but to decide sometime upon the change of the morphology of the disease or biology of the disease, and it helps to take clinical decisions for medical oncologists. I don't see Dr. Kishore still is trying to join in, so we can ask the surgical questions. But we don't have a surgeon apart from Dr. Kishore. So, sir, the Russian vaccine news came in. No, we all started getting phone calls, WhatsApp about vaccine. So we should utilize this forum because Voice of Healthcare has a lot of followers. You tell me about cancer vaccine, and this is probably the first of its vaccine in cancer, sickle cell T. And it's more than a decade it's there, and it has they have tried, and it's still in the NCC and IC as a level 1 evidence. Obviously there are cost issues, and after that docetaxel came, cabazitaxel came, abiraterone, enzalutamide. At the same time these drugs came ahead because of less toxicity, less financial toxicity. But I see apart from BCG, which is also a therapeutic vaccine in urinary bladder, so I see urology in your your interest of area is urology. One is BCG, is bladder cancer, and the second is sickle cell T. A word about this quickly, so that uh, Russians are not the first to get into vaccine because vaccine was there before. Quickly, and then we'll go to the immunotherapy part.
So, just before I explain simplicity, you risk stratify the prostate cancers as very low risk, intermediate risk, high risk, and of course, very high risk. So, simplicity has been there for donkeys of years. Probably in India, because as you rightly said, because of the availability, you're not able to use the vaccine. But the area where it is justified is the very low risk area, meaning thereby where the volume of disease is less and the conventional high risk markers which are there, they are not there. So if you have a patient which conforms to this strata, probably that is the place where you can use Cipla-Cel-T. It has been around for a very long time. So I think that would be the area where one would, provided it is available in the country.
Yes, absolutely, absolutely. So we have Dr. Kishore back. So
Yeah,
again, sir has mentioned about metastatic setting, low risk,
sure,
low risk, and there we were talking about the
sure.
vaccine in cancer. So you also stratify patients very low risk, intermediate risk, high risk, and very high
Yes,
risk. So quickly
yes.
about that, and then we were talking about robotic surgery. How the
Yes.
robotic
So,
surgery
yeah,
has
coming
evolved.
back to the robotic surgery, you can hear me now well, no?
Yes, 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 absolutely.
You can, okay, perfect. So basically, when we have low risk patients or like early disease, we get better results because continence and erectile function are more. But on the other hand, locally advanced disease and these continence may not be as great as early cases. So that is what one difference. And regarding the question regarding the oligometastatic disease, because there is a choice between radiation and hormone. So if there is an oligometastatic disease and patient has, I mean, quite a bit of local symptoms, then I go for prostatectomy and then do the whatever systemic treatment is possible. On the other hand, not much of local symptoms and the patient is comfortable, probably I would prefer RT over surgery and then start the systemic treatment. So and regarding robotic surgery, because it has been a game changer, because prostate is a very difficult organ to approach. Say, unlike spleen, it is situated deep inside the abdominal cavity, and it is blending with the surroundings, like bladder, sphincter, a lot of nerve bundles. So it's quite difficult to remove. So robotic has really made the difference because you get access to these nooks and corners of the abdomen very easily. And one of the danger of open prostate surgery is that you can have potential massive bleeding. It does not occur in robotic surgery because because the pneumoperitoneum that we create, most of the bleeding actually stops with the pneumoperitoneum. So we don't get much bleeding. It's faster, it's easier to do. Incontinence is very less. Erection is fantastic, especially in early cases. So it offers a, I mean, whole spectrum of advantage. And which I feel from oncological perspective also, we can get better cancer removal even in local advanced cases. So that has definitely been a paradigm shift in surgical management of the prostate cancer.
So one quick question about no use of androgen deprivation before surgery. So do you get an advantage in terms of no doing surgery or bringing down the disease burden, getting good planes when you operate to get a clear margin? Because most
Yes,
of the time we
I
end up
do.
giving
Yeah,
radiation post
so
surgery.
no, traditionally it has been thought that no androgen deprivation makes life difficult for the surgeon, and I think it's true to some extent. So there are specific indication I would say there is a patient with lot of local symptoms of rectal tethering. You give one shot of anti-androgen, that fixicity is reduced, and you can do the surgery later on. So after 3 months or 6 months. So selected cases, I would say mostly locally advanced cases, but not in organ confined early cases. I don't think there is indication because it makes our nerve sparing difficult. It makes the planes of surgery difficult. So I would say it boils down only to locally advanced cases where there is surrounding fixicity.
Thank you so much. So coming to Vineet sir, now we have talked about no the anti-androgens, androgen deprivation, early stages of surgery. We don't have a radiation oncologist amongst us, but radiation is also coming up an alternative modality for surgery, and there are cases who are not fit for surgery, and those cases can be considered local radiation or oligometastatic cases who respond nicely to systemic therapy, and patients are living longer, and you have very good disease control. Can we consolidate that kind of therapy? Because a lot of papers, even from India, Dr. Vendamurthy has no published papers for local radiation. And for those patients, not all patients, but a selective group of patients who are not fit for radiation, also emerging as a modality for early stages. A quick word, Dr. Vineet sir.
Yeah. So, as you rightly said, that given a choice, it would be surgery. But if you have a patient who's very old, poor performance status, poor general condition, these are the patients who benefit from surgery, from radiation. And whenever we embark on radiation, probably initially you have to give the ADT first for some period of time, and then after that you give radiation. If it's high risk, then probably you continue post radiation for about 1 to 1.5 years. So that is the basic schema which is followed.
Sir, again, I will continue. No, I'd like to continue with you only. The Dr. Professor James Allison is here in India. No, he is the pioneer in immunotherapy. And you mentioned about MSI. You mentioned about immunotherapy combinations. You spoke about no vaccine, which is also part of. Then there are attempts have been ongoing. We have targeted therapies. We have BRCA targeting BRCA. You mentioned about that also. CAR T is evolving. Lymphoma and leukemia, now we have our own indigenous CAR T. Rahul is a very good friend from IIT. Hasmukh has done a fantastic trial, and now they have crossed nearly 300 patients. We are still lacking in solid tumors. Yes, there are attempts in India as well as going on for solid CAR T. We have discussed one of the phase 1 trial, which is ongoing and promising results, but we have a clear antigen, PSMA antigen, and it's a clear target, which is easier for a CAR T to design CAR T. So, do you see a future for CAR T in prostate cancer?
See, as I told you, all these newer therapies, if you see the history of the drug or history of these therapies, they start from third line, fourth line in the metastatic setting. And then over a period of time, when you have more trials maturing, they come as first line metastatic. And then after that, once we get more confidence, they go up to the adjuvant, neoadjuvant settings,
Right.
where they have already proved their metal in the metastatic setting. At this point of time, CAR T in prostate would be a long shot at this point of time, specifically.
Absolutely, absolutely. Yes, yes.
Yeah, because we have phase 1 trials, or maximum, I think I can recall 1 or 2 phase 1 bar phase 2
Yes.
trials. And I guess as the CAR T gets matured, the quality improves, then these kind of drugs will come into the front line, and then I think we can get the best benefit out of them.
Absolutely,
There
absolutely.
another thing like bispecifics, they are also coming in a big way. I think that would be, immunoconjugate, that would
Yes,
be the way to go.
yes. I think bispecifics will move very fast as compared to CAR T. Uh, so Ravi, we talked a lot about targeted therapies, precisely, looking at personalized therapy. But still, what we see in our practice is chemotherapy or first generation, second generation anti-androgens. So how do you sequence these? Once you get a patient of castrate-sensitive prostate cancer in a metastatic stage and moving to a resistant phase, how do you utilize the existing therapy, be it lutetium therapy, be it chemotherapy, cabazitaxel or docetaxel, abiraterone? There are newer agents now available. Apalutamide is also available now. Dara is also available. So how do you sequence these? And do you use any, biomarkers? We don't have precise biomarker as of now, but a lot of genomic sequencing is easily available. Do you practice that? So quick word about that. No?
Yes. So while treating prostate cancer, we generally divide prostate cancer into castrate sensitive and castrate resistant. So treatment algorithm is different for both castrate sensitive and castrate resistant prostate cancer. In castrate sensitive prostate cancer, we generally divide this cancer into mainly bulky disease. Those who are bulky, high volume disease, they generally required, in addition to androgen deprivation therapy, they required probably androgen receptor pathway inhibitor, abiraterone, enzalutamide, or apalutamide. And in addition, we have option of addition of chemotherapy. So those patients who are having high volume disease, I add chemotherapy to ADT, androgen receptor pathway inhibitor combination. Those who have low volume low volume castration sensitive disease, uh, apart from androgen deprivation therapy, I add androgen receptor pathway inhibitors. Those who have oligometastatic disease, this is separate group of disease. Probably it is low volume disease but metastatic and castration sensitive disease. Probably we treat with curative intent. So in addition, ADT and androgen receptor pathway inhibitor, we generally add local radiation to prostate as well as some 2-3 few metastatic sites. But while treating castration-resistant prostate cancer, we have multiple options from androgen receptor pathway inhibitors to chemotherapy, target therapy like PARP inhibitors, olaparib, rucaparib, then immunotherapies for MSI high tumors, then lutetium PSMA therapy, then we have option of radium therapy for only bony metastasis without any visceral crisis. So while sequencing, probably for all patients we give ADT plus androgen receptor pathway inhibitor initially. Those who have received, we try other drugs. Initially, I try androgen receptor pathway inhibitors with chemotherapy for high volume disease in castrate-resistant prostate cancer whenever chemotherapy is not used previously. But before chemotherapy, I generally test them for BRCA mutation because there is no data PARP inhibitors after chemotherapy. So while using PARP inhibitor, I generally start them before chemotherapy. So at day one in castration-resistant prostate cancer, we test for germline BRCA mutations and if, or HRR pathway mutations, and if HRR pathway mutations or germline mutation is positive, then we can have option of addition of PARP inhibitor to androgen receptor pathway inhibitors. And chemotherapy, we generally sequence after PARP inhibitors. Regarding immunotherapy, it is clear-cut option for MSI high tumors because they have got high chances of response as well as improvement in overall survival. Regarding radium 223 therapy, those patients who have only bony metastasis or very low volume of visceral disease, they are symptomatic for bony metastasis. We have option of radium 223. And after androgen receptor pathway inhibitor, we have option of docetaxel. With after progression of docetaxel, we have option of cabazitaxels. And if after docetaxel, when we get DFI more than 1 year, probably we have option of rechallenging docetaxel, because docetaxel is one of the important drug in prostate cancer. That's how I sequence management of prostate cancers.
So, no, lot has been said about systemic therapies. Dr. Kishore, quickly the last question to you of this
Sure.
session, because we have missed you. A lot of discussion was going
Sure,
on.
sure.
So nowadays, you see the systemic therapies evolving. The medical oncologists are taking the center point of view. But yes, the still patient comes to you, and
Mhm,
this is the era of precision therapy, personalized
mhm,
medicine. Do you see any? We talk a lot about AI is evolving, the artificial
mhm,
intelligence, and
mhm,
Bangalore is a hub for the techno, and
mhm,
obviously you are closer to that. So, do you
mhm.
see AI is going to help us in digital imaging, the MRI images? Is the future I'm looking at, or digital pathology, where you as a surgeon can tell, no, in future this is going to be the indolent disease based on the traditional markers and the digital pathology and the digital AI, and then you can actually foresight, or you can see the patient's future, what
I think
therapies.
no. Yeah, AI definitely has a role, evolving role in the MRI aspect of the prostate cancer, because there's a lot of heterogeneity in diagnosis of reporting the prostate cancer. So AI might it make it more uniform, and of course, incorporation of AI into the surgical technologies, like superimposition of the MR images into the surgical field. All these things can improve on the surgical precision. Can you hear me?
Yes, yes,
Hello?
yes.
Yeah. So all these things can improve on the surgical precisions. As far as the personalized medicine is concerned, I think probably better people will be you, medical oncologists, to talk about. But I feel definitely from a surgeon perspective, no, we are going to have more and more AI involvement, especially in robotic surgery, because it's a computer-assisted surgery. So integration is much more easier than open surgery. So we are probably going to get better results, more precision, and less learning curve in surgical procedures. And of course, in diagnostics, with the already it's the with the advent of AI in MR diagnostics, I think it's going to have a even more role in the future. Actually.
So your voice is not audible, sir. But sir,
The
your
robo
voice.
is going to learn the robotic surgery, and probably the surgeons are moved out of the OT in the next row to the console, and probably they sit home and will do the robotic surgeries. Where do you see the AI is helping us to stratify our patients? No, and because we do a lot of sequencing, probably the sequencing has become so cheaper now as compared to the Western countries. It is available, and the Indians labs are also doing equally good job. I think we should thank to them. They're bringing the cost down. Otherwise, spending thousands of dollars on even diagnostic was very difficult. It was not accessible. You have seen trials changing the landscape of the disease, but accessibility has been a bigger issue for largely for the low and middle income countries. So do you feel in the future all these genomic markers signatures become like a PSA, cost of PSA, you have ctDNA is available? Do you think things will be different 10 years from, or 5 to 10 years down the line? Because I joined as a fellow, then there was nothing in the prostate cancer. Docetaxel had just came, and now I see there are so many things coming up daily basis. So, and people come to us to know, because chat GPT is there, they can put up their questions and they can get the consultation over there. But we have to remember that the good clinician is not replaceable in AI era. What quickly a word about that?
Well, AI, as uh, was told by the surgeon, apart from that, when we talk of data generation, if we have to publish papers, you get a very good stratification when you use AI in a high throughput analysis. Secondly, if you have to answer a question which requires going through a lot of data, that is again where AI is going to help us. Thirdly, in radiology and histopathology, where presumptively, if the radiologist or the histopathologist misses some areas, AI would, bring it up as pop-ups, and they can be again screened. Although, AI can do that much only, the human intelligence is the one which is going to be paramount, and the discretion would still lie with the treating doctor as far as the final treatment which has to be chosen. Having said that, yes, these are going to be very, very important tools in the future. And as we are going into an era of precision medicine, we are going from macro to micro. Definitely, that is the way to go. And it is going to help us also in decision making. And the chances of errors are going to reduce. And that, at the end of the day, would lead to a better quality of life and quantity of life as far as the patient perspective is concerned.
Ravi, would you like to add anything? So, Dr. Kishore, a quick comment about about patients relatives who are listening about prostate cancer. It is definitely a disease which can be cured. Early detection is the key, but detection does not mean always a treatment. There is always our subset of patients where full watching. The patient factors are important, the tumor factors are important, and patients should take proper consultation of a team of doctors, which involves medical oncologist, surgical oncologist, and the radiation oncologist and nuclear physicians. And in our country, social workers are also important part because the finances are important. So we have the next set of panelists coming in. So Dr. Kishore, before leaving, you can tell something about our prostate cancer patients or the relatives quickly in one line.
Yeah, I think the prostate cancer can be a sheep in wolf's clothing. There is a general impression that prostate cancer is follows a very benign course, but that is not true. Some prostate cancer has to be taken very seriously. That is what probably my message is.
Thank you. Vineet sir, for all our
Yeah,
patients.
yeah. I think the way to go is precision medicine. And as the time passes, we will get more and more clearer as to how to treat these patients. And especially in the castrate resistant arena, where the time at this point of time is just 1.5 years. Probably with the precision medicine, we are able to stretch it like what we are doing in the castrate sensitive arena. So patients will be able to live more, which is what we want and what the patient's attendants want.
Thank you, Vineet sir. Thank you, Dr. Kishore and Ravi, for enlightening our listeners how the treatments have evolved. Now we have the next segment, and thank you very much for being part of this discussion. So I'm moving to next set of
Thank you.
panelists. I hope
Thank you,
everyone.
doctor. Yeah.
Thank you, Ravi. Thank you so much. So, sir, you have already been introduced. Dr. Shyam Aggarwal is everyone in the oncology. Almost all the panelists, they are all good friends. But Shyam sir has been mentoring to all. No, he has been mentor to most of all of us, and especially for me, both in oncology as well as non-oncology musical thing I'm talking about. He has been the key leader in oncology in India and being part of various guidelines here when he is around there, all the educational session. The next is Dr. Krishna Prasad is a good friend from South, and he is again fantastic orator. I always love listening to him. So today, apart from Shyam sir, we have Dr. Rajesh Patidar. He's a medical oncologist, and we have Dr. Ankit Patel. Hi, Dr. Ankit. So we all are medical oncologists. There is no, so there is no radiation oncologist. There is no surgeon over here. The previous session we had, Dr. Kishore as a surgeon. So probably I can come to Krishna Prasad to ask about radiation and other panelists for nuclear medicine queries. So in the first segment, we have largely covered about early stages because surgeon was there, and we have spoken about little bit about chemotherapy and targeted anti-androgens. Largely, we have spoken about newer treatment approaches which are evolving, including AI and immunotherapy, cancer vaccines. We have audience which are patients as well as their families or doctors. So I would like to start first with Dr. Krishna Prasad. We have now a broad therapeutic landscape. When you and me started, there were hardly any treatment. Shyam sir, your era, you have probably those Honavan hystrogenic agents, and chemotherapy was not part of treatment. Only anti-androgen, taking out the testicles or giving the injections 3 monthly or monthly. So now, Krishna Prasad, we have a lot of not lot of the 2 or 3 chemotherapy agents. We don't use mitoxantrine nowadays, and we have anti-androgens. So when you have a patient in front of you, how you decide about this sequencing, how you choose the chemotherapy wisely? Does every patient
Okay.
goes for chemotherapy who comes to you, or do you consider some patient factors, tumor factors, and side effects?
Yeah. Thanks, Bharat, for having me. So I think when we look at prostate cancer and we tend to use chemotherapy and other agents, I think what we are discussing is metastatic prostate cancer, right, in the present scenario.
Yes.
So we need to look at the basic treatment. The basic treatment in any metastatic prostate cancer is androgen deprivation therapy. So irrespective of whether you're going to add anything or not, the basic premise is androgen deprivation therapy is going to be there on a continuous basis. Now, how we do it is either we do a surgical castration, that is removal of the testes, or medical castration, in which we have either injectables which can be given monthly or 3 monthly, or now recently we have got oral drugs as well. This is the basic treatment. Now, in addition to that, we have newer agents as well as some older chemotherapeutic drugs which we can use. Most of the patients in the present day and age would receive something more than androgen deprivation therapy. Now, most of the time we would use a newer anti-androgen, which is either an abiraterone or enzalutamide or apalutamide or darolutamide. All of them are oral drugs and generally given on a continuous basis. In addition to this, if somebody is a younger patient, seems to have a lot of disease burden, what we term as a high-risk disease, that means the number of metastatic sites are large in number. In those kind of patients, we tend to add chemotherapy as well. So the basic plan is everybody should get an androgen deprivation therapy. Most of them would also get another anti-androgen newer agent, and few of them, if in their younger age or an aggressive disease or large tumor burden, would receive chemotherapy as well.
Thank you, Dr. Krishna Prasad. So, Shyam sir, coming back to you, we have discussed, as I said, there was a surgeon with us, and early stages we discussed. But again, I would like to touch upon that point. We are promoting screening, early detection, and prostate cancer is one of the cancer which obviously happens at the old age. People do come for health checkups. So apart from PSA, digital rectal examination, any other tool you have been using it? Because a lot has been coming up in the media, a lot of tests coming up for various cancer screening, but nothing is proven so far. And people are confused when they end to see in the media because it's influential for them. So a word about screening and PSA as a backbone of screening with digital rectal examination, or anything else you have been practicing, because this is the era of precision medicine. Liquid biopsies are easily available. People are getting easier access, but people should know what is right, and quick word about that. What should people do when they come with the diagnostics? Sir, you're mute. Sir, you're on mute. Oh. We are still not able to hear you, sir. You can probably switch off the camera and then try speaking. Oh, probably there is some problem with the network. We can see you properly. I think other speakers are able to.
Yes.
Yes.
No, he's still not audible. Sorry.
So I'll come back to you, sir. You can fix up that problem. So I'll take another panelist in. So Dr. Rajesh, till the time sir is back, so I would like to comment you on the newer therapies. So do you really see, immunotherapy is now used everywhere? Do you really practice it? No, we talked about MSI, we talked about sequencing the tumor, because you can take a biopsy, you can take a blood, you can see access is a little bit better, and there are people who can afford it financially. So do you in the beginning only do all those marker including the MSI, because immunotherapy is easily accessible now? Rajesh, you have to unmute.
In my practice, I have started doing MSI in all metastatic prostate cancers. And in last 5 years, what I am seeing that many people are taking treatment on immunotherapy, since these drugs are cheaper now. These are like they were costly 5 years back, but now they are getting cheaper year by year. And maybe next 1 or 2 years we'll be having our Indian immunotherapy generics one. So we will be able to provide more to the most of the patients.
Thank you. So I think sir is trying to log in again.
Can you
Sir,
see
we
me?
can see you. Yes, sir. We can see you and we can hear you. Thank you.
Right. So, before I answer your question on screening, I think you had in the previous discussion and even now you were asking about the role of radiation in the management
Yes.
of prostate cancer. So I think radiation has an extremely important role in patients with the localized prostate cancer, and it offers almost same outcome than as compared to radical surgery. I think in Europe, a lot of centers practice radiation for early localized prostate cancer or for patients who have oligometastatic disease. And earlier people were talking about 5 to 6 weeks of radiation, and more recently, even 5 days of SBRT has been considered to be equivalent because the data appeared very recently in meta-analysis and from a couple of centers. And I believe our radiation oncologist had visited Royal Marsden recently, and I think they are also talking about 2 days of radiation, and in 2 doses they finish the treatment. So that's the kind of progress which the radiation oncologists are making in the management of localized prostate cancer when the disease is confined to the prostate alone. So I thought I'll just share this information with you and with the people who are listening to this discussion. Now coming to the screening part. So I think Bharat, this is the one of the only cancers in men where you have this tool of prostate specific antigen available. And if you look at the methodology, there are three things which are seen. One is a total PSA level. A second is the free PSA level. That is the PSA which is not bound to the proteins in the blood. And third is the one which is the pro PSA, which is more relevant to prostate cancer. So, by devising this particular ratio, one can figure out to some extent, that the patient may be having prostate cancer. So it's called prostatic health index, and it's not an absolute test. It's not a replacement for DRE. It's not a replacement for biopsy. But I think if the PSA is more than 5 or 10, I mean, the this ratio can help us to take a call whether to go in for further methods to identify whether the patient has prostate cancer or not. So that's one thing. The other thing which people should be aware of is that as we grow in age, the PSA levels also increase. So PSA is a protein which is secreted from the prostate cells, and the actually the levels are high in semen, but they also are in blood. For example, if somebody is between the age of 70 to 79, then the upper limit goes from 4 to 6.5. And if somebody is under the age of 50 years, then the upper limit can be 2.5 or 3. So it varies according to the age of the individual. So these are some things which we need to remember when we are looking at a test which comes from an individual. Anybody who has UTI or urinary infection, so they can also have high PSA levels, and therefore one has to be careful in going further and advising them maybe expensive tests like MRI or PSMA, etc., just based alone on the basis of PSA tests. So, but suffice it to say, I mean, it's a test which can guide us, but you need to read it judiciously to perform the digital rectal examination, the MRI, and if required, a biopsy to confirm the diagnosis of cancer. So PSA levels are not confirmatory. It's just a screening tool which can, help us to take a call further as to what investigations we should perform to rule out or to confirm whether the patient has cancer or not. So that will be my take on PSA.
Thank you so much, sir. So to our listeners, it is very important when the PSA is high, please do consult the oncologist, urologist, and get it confirmed. It is something which is treatable. Sometimes you are dealing with some infections, probably, and if it is a malignancy, you still can cure it in early stages, or sometimes you can just observe things. So coming to Dr. Ankit, so sir has nicely mentioned about the PSA screening. What is the practical implication? What do you see actual life, on ground? People are doing PSA on their own. Lot of, I think you are traveling, so you can brief all the practical implications of PSA screening, and how do you see patients are getting diagnosed or getting treated, over treated or under treated, or sometimes no lead bias is always there, because by doing test you pick up some of these cancers. So age also is important. At what age you are diagnosing? Sometimes you have a 91-year fit guy, and sometimes you have a 75-year-old frail person, bedridden. So all these factors are important. So a quick word about that.
Thank you, Dr. Bharat sir. First of all, most of the time, what happening because of an many screening tool available by our commercial laboratory, patients after 50, because of word to word or whatever they search on net, they go for only PSA testing without going digital rectal examination. And many times the PSA comes borderline 5 or 6. They become very worried about the malignancy. They didn't understand it may be due to because of a bulky prostate or because of a prostatitis. I have seen one patient doing a PSA around 110. Ultimately, it was turned out to be prostatitis rather than a malignancy. The neurosurgeon, after giving antibiotic, also then PSA subside, because we all know more than 100 there are high chances of malignancy due to biopsy, but ultimately biopsy didn't turn out to be any malignancy. So many factor without digital rectal examination or sonographic confirmation, only PSA is always misguiding, and many times it is very cumbersome to the patient when the reports comes borderline, particularly when the reports comes around in between 5 to 10. Because many times patients are afraid of DRE, also digital rectal examination, but we should know that it is not frequently required. It's required for 18 to 24 months, hardly 1.5 year to 2 yearly by expert surgeon or urologist. So only PSA have no role without digital rectal examination, and you should go for screening after consulting. It is my recommendation to all my patient, because when you require what are the comorbid you have is also important. If any 70-year guy already having a COPD, having a cardiac condition, overall survival is not good, and that case is I don't think PSA screening were having any good help.
Thank you, Dr. Ankit. Dr. Rajesh.
Yes, sir.
Yeah. So moving from the screening and testing, coming to the treatment part, Dr. Krishna Prasad has though nicely mentioned about all the treatment modalities available. We have moved from last decade to this decade, chemotherapy, oral anti-androgens available with us. When you have too many options available, it is very difficult to choose. And especially now we talk about immunotherapy also. There are phase 1 trials of CAR-T. There is a vaccine which has been there, but we haven't utilized it because we have other easily accessible and less toxic agents. And then we have genomic tests available. And we know that BRCA is one of the actionable thing. And we have a drug now. Generics also available easier. So then sometimes taking decisions become difficult. You have a ability to decide on that. So coming specifically to the BRCA, as you mentioned that you would like to utilize all these treatments. So where do you see the treatment targeting and whether you do it for all patients, somatic or germline, or how do you counsel the patients?
So, sir, now we have generic PARP inhibitors. So, most of our patients can afford those drugs. So, whenever there is a indication like all metastatic prostate cancer, I counsel them to get HRR if possible. If not HRR, then at least BRC, germline, BRCA1 and BRCA2. So, if HRR comes positive or BRCA1 or BRCA2 comes positive, then it also a prognostic marker. If those things are positive, then patient will not do good. And this also have a therapeutic implication. We use olaparib or other PARP inhibitor along with abiraterone or other other drugs whenever it is indicated. So I am
Right.
doing this in my practice.
Thank you. Coming to Dr. Krishna Prasad, now you started about this landscape, so I will come back to you. Now I think we have most of these things available to us, so it becomes a huge of knowledge and it's a responsibility on us when we know, and these are costly things sometimes, and patient also gets confused. Apart from that, there are nuclear therapeutics available to us. They are also effective but in a clinical trial setting. But ground reality when you have all these modalities available. So as a part of guiding clinician, it's a responsible thing for us to sell through as a guidance or a mentoring the patient and patient's family. So where do you see this modality being utilized on the ground, be it BRCA, be it immunotherapy, HRD, which is largely being utilized in ovarian cancer? But no, you can send the tissue and get it done. But again, this is a costly test. So do you think we are utilizing these biomarkers today, or yet it is not being utilized, or may not be cost effective? What is your take?
Yeah, I think the cost effectiveness of this test depends on the availability of the drug. And like my colleague has pointed out, with the availability of generic PARP inhibitors, the accessibility to these drugs is there. And hence, I think this test is also reasonably to be done. Now, when do we do it is the question, and how do we do it? Ideally, I think there are two options. One is to do it in the blood, and another one is to do it on the tissue. There is always an issue with getting it done on the tissue because many of these patients have had a diagnosis of prostate cancer many years back, and now they have bone metastasis. And biopsying the bone and doing this genetic testing on this bone piece is extremely difficult because when you decalcify the bone, some of this genetic information gets destroyed. So I think as a minimum, it is better to do at least a blood investigation for a germline mutation in BRCA1 and 2. Of this, BRCA2 is the most important one and probably is the one where maximum benefit is proven in terms of using the drugs. The other mutations which can be picked up on the tissue, there are studies and there is some benefit. The benefit is not as good as somebody with a BRCA mutation. So if you look at the other way around, I think it is important not to miss BRCA2 mutation. And if you use all the other drugs in patients with some of the other mutations, it is not wrong. But missing BRCA2 mutation would deprive the patient of a very good treatment option. When to
Absolutely.
do it again? In the initial hormone sensitive setting, when I spoke to you about using the anti androgen deprivation therapy and using the newer anti androgen, that may not be the situation of using this drug. But in patients who go through these treatment and then ultimately quite a few of them develop resistance to the treatment, that is the time probably you would use it in the present day and age. Of course, there are enough studies now to test to use it earlier also, but in the Indian setting, probably you would use it in patients who have failed the standard anti-androgen therapy and chemotherapy.
Thank you, Dr. Krishna Prasad. When no, we have effective agents, one must do. I don't see Shyam sir because I was about to know get him into the discussion. Till the time he joins, we can.
Bharat, I'm here.
Shyam sir, yes sir. Sorry, we missed you for seconds.
Yeah.
So sir, now Dr. Krishna Prasad has mentioned we have actually a lot of drugs available and they are generic, easily accessible. There was a time we know that we have faced getting access because of the cost, they were not available. So prostate is a disease where you see patients living beyond 10 years. The biopsies are done decades back and now patients comes to you with bone metastasis. But sir, now many laboratories are doing the fantastic job in terms of getting the liquid biopsies in India, and the cost, I think, today we can say, looking at 5 to 10 years back, they are easily accessible. Not for all patients maybe, but for large number of patients. So liquid biopsy, it has almost replaced, you need to have diagnosis, but lung cancer, you see, many other cancers, we are doing liquid biopsies. People are trying to look at the MSI index in the liquid biopsy. So it is available to us. So do you see a future or no current era where we are utilizing, when in other cancers where you can use it in prostate, where tissue is sometimes is a problem because these patients are diagnosed before bone biopsies? Yes, you can
Right.
do it.
Right. So I think it's a very pertinent question. Am I audible?
Yes, sir. Yes.
Right. So I think, as was mentioned by Krishna, most of these patients would have had a prostatic biopsy done a few years before, and over a period of time, which is spanning beyond 2, 3, 4 years, they tend to progress, and the utility of targeted drugs like BRCA1, 2, or ATM, like with the PARP inhibitors, comes several years after the initial diagnosis. So, that is the perhaps one justification as to, or thought is, when to perform the, genetic testing in a patient with advanced or metastatic prostate cancer. So I think the guidelines do suggest that even at the stage of hormone sensitive metastatic prostate cancer, one can perform the on the tissue itself, the genetic testing with BRCA1, 2, or with the HRR genes, as they said. But the another point to understand and to remember is that as the disease becomes chronic and progresses more and more to bones and other parts of the body, so more and more patients will acquire BRCA1 and BRCA2 mutations. For example, at the stage of HSPC, if the BRCA1 2 is mutated in about maybe 15-20%, so maybe 5 years down the line, I mean, you'll add another 10-15%. So therefore, if you don't have the tissue down the line, say 5 years hence, I mean, you have no choice but to do the blood testing or the liquid biopsy, as we call it, in which you are not only looking for, the germline testing, but also the acquired somatic mutations, which could be either BRCA1, 2, or other HRR genes, or other acquired mutations. So, if you look at the acquired mutations, so you have those tumor agnostic indications in which genes like NTRK, PIK3, or mTOR, and similar genes are found to be mutated, where you can pick up those abnormalities and target them with suitable drugs, which have now become available. So I think a liquid biopsy is considered to be at par then as compared to tissue, with almost 95% or similar, concordance, whether you do the liquid or in the blood or you do in the tissue. So I think liquid biopsy has a role to play. And also, people are doing that, for example, in breast cancer and certain others, to monitor the progress of the cancer and pick up more and more, mutations and target them. That's one. Second is the tumor mutation burden, which again can be, easily figured out, and can give us the guidance on the use of immune checkpoint inhibitors in patients as a tumor agnostic marker. MSI can also be picked up by few labs using bigger panels and doing the large panels for liquid biopsy. So I think that's where we stand in terms of liquid biopsy in prostate cancer. I think we've got a lot to do, especially when we will be doing deep sequencing. I mean, we can maybe pick up subclonal abnormalities which may be amenable to targeted therapy. So currently, we do have some targets which are available, but I think a lot more needs to be done.
Thank you so much, sir. So you quickly, mentioned nicely about liquid biopsies. To tell our audience, liquid biopsy is nothing but taking the blood and looking for the circulating tumor DNA which comes from the tumor, and try to look for these biomarkers, these mutations which are actionable or druggable. There are drugs available which can change, which we call as a personalized or precision medicine. And fortunately, we have a easy access with their cost has also come down. So Dr. Rajesh and Dr. Ankit, do you see increasing utilization of the liquid biopsy across the tumors, and especially now we are talking about prostate cancer? So quick word from Dr. Ankit and then Dr. Rajesh. Dr. Rajesh, you can start and then we can.
So, particularly another cancer having a wonderful
I think there is a
role of
network
liquid
issue. Dr. Ankit, I think there is a
we first started from the lung cancer, then colon having a also wonderful role when
Dr. Ankit would like to come to you again because there is some problem with the network at your end. So Dr. Rajesh, I would like to request you to come in, Dr. Rajesh Patidar.
Yeah, yes. So liquid biopsy is very easy to do. It is a non-invasive procedure. We just take a 2 ml of blood and we'll send to the lab. We are using it frequently now, especially in lung cancer and even in a prostate cancer where blocks become old, HRL becomes failed. Then we try to do it in blood so we can get the failure rate might decrease. So in a lung we are commonly using, and even in a prostate cancer, especially for HRR, and we are doing this liquid biopsy frequently.
Thank you. Dr. Ankit, you can speak now. Now I see your image also clear.
Okay. From our experience of lung cancer, we are nowadays all know we are using liquid biopsy very frequently, and in colon cancer also. Particularly the prostate cancer patient, when the tumor is progressing, particularly in bone, so it's very difficult. Already we discussed previously to get a biopsy from the bone because many genetic abnormality will be missed because of the decalcification process. So liquid biopsy have a role, but practically speaking, at present the treatment, in particular for prostate cancer, we are talking, the treatment decision will be changed in hardly in 2 to 3% of the cases. This is so highly recommended when the all standard chemotherapy and oral medicine options are failed. We have to rely on liquid biopsy report for the new modality of treatment.
Thank you. So now all the panelists are agreeing that we have all these modality of diagnostic predictive markers available to us, all the drugs are available. It is how you utilize one drug after the other and ultimately see the ultimate survival is improving. So Shyam sir, now we have so many agents. This is a disease, sometimes very dormant, sometimes very aggressive. So we don't want to the fear of missing out is also there. Or sometimes there is very rarely there is a overusage. So the oncologist's role is very, very critical over here. There are a lot of biomarkers to guide. So how do you see the treatment which is evolving from the androgen deprivation in the form of simply taking the orchidectomy or giving GnRH analogs or anti-androgens, and now there are so many agents. Just you have to utilize them one after the others, and the changes that happened in last 20 years, sir. So how do you look at it?
Absolutely, yeah. So, when we joined oncology maybe 30 years ago, so even in a 70-year-old person diagnosed with prostate cancer, which is localized to the prostate area, people were offering orchiectomy, that is removal of the testes. So I think even the surgeons were perhaps not, geared up for doing radical prostatectomy at that time, especially in elderly people or even in 60s, patients age 60s. So, there is a huge shift in the, paradigm changes there in the last 10 years or so, as was being discussed. Robotics has entered the surgical arena and has made life easy for patients in terms of side effects and better outcomes for patients with localized prostate cancer. And as I said in the beginning, so patients who are relatively unfit for surgery can undergo radical radiation with similar outcomes and fewer side effects. So when it comes to advanced or metastatic prostate cancer, so we have in the initial stages we call it hormone sensitive prostate cancer, and we have three modalities to offer. One is the orchidectomy or LHRH drugs, which can be analogs or antagonists, and that's number one. The second evolution which has happened is we have the second generation, drugs like abiraterone, enzalutamide, apalutamide, and darolutamide. So earlier people were using calutide, which still I see a lot of urologists using it upfront. But then I think in our practice, we have almost, stopped using it. And the third in first line has come is a combination of chemotherapy with the castration drug or surgery and the use of abiraterone. So, in a fit patient who is under the age of 65, 70, with extensive disease in the bones, which is where the prostate cancer tends to metastasize, so the three drug combination gives you the best outcome. However, in a patient with limited disease, there one can may not use docetaxel, which is the chemotherapy drug, or a patient who is elderly beyond 75, 80, where you can only use the hormonal therapy such as LHRH drug or and combined with either abiraterone or enzalutamide. These are the two common drugs. So once you have a patient with metastatic disease, eradication of that cancer is usually not possible. Fortunately for us, the hormonal therapy with the LHRH drug and the new generation, the inhibitors, people tend to live quite long, actually. I mean, we have patients going beyond 2, 3, 4, 5 years. So it's not and these are drugs which are extremely well tolerated. We're not talking of chemo if you're not using chemo. And patients go on for a long period of time. A new modality, which has come up after the failure of these drugs is the use of lutetium PSMA therapy for patients who have PSMA avid disease. So the PSMA PET scan is a very important tool in monitoring the disease and also figuring out the the treatment for such patients who fail hormonal therapy and even chemotherapy in the first line. So I think lutetium. So we have more frequently, requesting our nuclear medicine friends, because that's a very easy treatment. The only thing required is that their creatinine should be normal and they should have a good bone marrow reserve function. And it's a very simple 2 hour treatment given every 2 to 3 months. And I have a couple of patients who have taken 6 or 7 of those injections every 3 months and tolerating extremely well, and their PSAs come down. So PSA level are used very frequently to follow up these individuals. So once you've failed the chemo, you failed the hormone, you failed the lutetium PSMA, then of course we are talking about targeted drugs like olaparib, for which HRR is required, and then of course the TMB and MSI for immune checkpoint inhibitors. And then we do have second line chemotherapy like cabazitaxel. So we've been able to convert metastatic prostate cancer in most of the patients as a chronic disease, and they actually lead a fairly good quality long life, even if it is diagnosed at the age of 70, 75 years. So one should not be scared of it. One has to follow the doctor's advice and sequence the treatment appropriately.
Thank you so much, sir, for summarizing all these things. So we have covered almost everything pertaining to right from the screening, early detection, including the surveillance part for very low risk patients, prostatic surgeries, including the robotic surgeries. Then we have talked about chemotherapy. We have talked about newer anti-androgens. As you mentioned rightly, using all the three therapies for a fit and heavy burden disease could not have been possible about well conducted research. So research access to clinical trial was once upon a time was difficult in India, but sir, you have been instrumental in bringing trials, being part of so many innovative trials in the past. A quick word about research to the patients to participate in clinical trials from you, sir, and then to Krishna Prasad, probably the last question.
So absolutely, all these drugs which we counted, and the use of the newer anti-androgens, the PSMA, lutetium therapy, the role of PARP inhibitors. So that's only been possible for example, the lutetium PSA therapy was used as third and fourth line, but as we find it more effective, or we found it more effective, so we enrolled patients in second line after the failure of hormonal therapy, and found it to be better than chemotherapy and other agents. I mean, that is how the treatment moves ahead, by enrolling patients, doing the same thing in 100 patients, which we've been doing for the last 5-10 years, and putting up a promising therapy in the second line, and then following these patients. I mean, that's one, that is enrollment in clinical trials, and trying to identify the efficacy and the safety of a particular modality, and that, as I said, the line of therapy. That's one area. The second is the role of genomics, because we need to, because these cancers are occurring because the genes are being mutated, or there are insertions and deletions. So in each community, whether they are Caucasians, whether they are from China, or from Southeast Asian countries, so the cancers can be different, and that can only be judged if you do sequencing in hundreds and hundreds of patients in that community, and therefore tailor the treatment according to what genes are found to be abnormal in a particular set of patients. So I think that is again molecular level basic research, which we must engage into, so as to identify our problem, that what are the mutations, what are the abnormalities in the genes in our country. So there are many areas of research which one can for example, prostate cancer goes to the bones, and one is talking about bone directed therapy. and pain is a very important feature. So nuclear medicine department does a lot of research in trying to target the bone lesions so as to alleviate the pain of patients suffering with prostate cancer. And these patients are elderly, and therefore they need palliative care. So that's another area which also needs to be highlighted, because these patients may be neglected by their families because they are elderly, and role of palliation is critical, so as to nobody should have pain, even if somebody is having incurable disease. So pain relief is extremely, extremely important. So a lot of research can be done in that direction. So I think there are a lot of areas for research, and prostate cancer is a common disease in people who are over the age of 60 years. So we need to address that problem. Thank you.
Can't hear you, Bharat. Bharat, we can't hear you. You are muted.
Sorry. So we are concluding here. We are already overshoot by 3 minutes. So quick word about advice to our patients. We start from Dr. Krishna Prasad. We almost covered all the points. Anything which left you can mention, and then you can give your closing.
Yeah, I think Dr. Shyam Aggarwal has made it very clear that early diagnosis of prostate cancer is extremely important. So PSA screening along with digital rectal examination above the age of 50 to 60 years, I think will go a long way in detecting prostate cancer early, apart from all the treatment which we have discussed.
Thank you, Dr. Kishore Prasad. Dr. Rajesh, a quick advice to our audience. Then I'll move to Dr. Ankit. Dr. Ankit, you can quickly mention about...
My advice to my dear patient: don't afraid of CA prostate cancer. Okay, don't afraid of CA prostate, as the data shows that only 4 to 5% of the cases of prostate cancer diagnosed may ultimately die due to prostate cancer, because most of the time they have many comorbid illness. So whenever you diagnose prostate cancer, don't worry, go for your treatment. Even if you are fragile, only ADT will also giving you a good quality of life. So this is my humble request to go and get a treatment.
Thank you. Thank you, Dr. Ankit. Dr. Rajesh?
So I will advise my patient that many people die because of with the prostate cancer, not because of the prostate cancer. So meet the experts and take treatment, and you will get the best result.
Sir, last word from you, Shyam sir. To all the patients, all the treating physicians, surgeons, or referring family physicians.
Absolutely. So I think since this is a disease of elderly individuals, so the comorbid conditions such as cardiac ailments, hypertension, diabetes, maybe cerebrovascular diseases. So I think they also need to be taken into account. And since these people live actually very long, I mean 5 years, 10 years, and so on. So a close, dialogue with the local GP is always helpful to, overcome those problems. And so I think prostate cancer, people really, really should not be hopeless. I mean, cancer sends, shivers down the spine, but we've seen dying patients walking for years after the use of hormonal therapy, which is extremely, extremely safe by and large, and no side effects. So I think we should be positive, and that message should be passed on to everyone who's listening this discussion.
Thank you so much, sir. So here we are concluding, and wonderful participation from all the experts across the country, very seniors and eminent oncologists we have today. And I have been fortunate to be part of this discussion. And definitely Dr. Krishna Prasad, the Shyam sir will definitely come up with a group discussion for music. And to the patients, first of all, I would like to thanks again Bharat Serum, Voice of Healthcare. World Cancer Day was a day back, 2 days back. And prostate cancer is really a disease of old age, geriatric population. And in India, we are going to have increasing number of geriatric patients, not only prostate cancer, but the other problems. As one of the panelists mentioned, they are already have so many comorbidities, and sometimes death is not due to cancer. So it is better to pick up early, treat whenever required, and go to a proper person or a team of person, which includes medical oncologist, surgical urologist, your radiation oncologist, nuclear physicians, and many a time we need counselors, because it is not something comes with a death sentence. These patients live 10 years, 20 years, if no properly diagnosed, rightly guided. And that is all I would like to tell the audience. And once again, I would like to thank all the panelists from the bottom of my heart. Thank you so much. If there are no more questions, we'll just wait for a few seconds, and the organizers can take a call, or we can conclude, and after 30 seconds we can leave the studio. Thank you so
Thank you.
much.
Thank you. Thank you very much for inviting.